Alnoor, thank you very much for this amazing, amazing talk. It was very informative, and I'm sure all of us really benefited from it. So, if anybody has questions, there are a few questions in the chat. Maybe I can start with that while people can raise their hands or, unmute themselves to ask the questions. So, one of the questions was from, oops, I lost the chat. One of the questions was from Malek Sultan Jivani. And the question was, what is vessel disease? I think where angiogram shows no blockage on main arteries, but issues on smaller veins or vessels or arteries. She doesn't know what that one is called.
Okay, that's an excellent question. There are 2 points you should know about vascular disease. When you do an angiogram, the dye is in the lumen, it's inside the lumen of the artery. So, what you are seeing is just the lumen. You do not get any idea about the wall of the artery. And it is in the wall of the artery that the atherosclerosis and the hardening of the arteries is occurring. So until that hardening or the atherosclerosis starts to impinge into the lumen, a patient could be having atherosclerosis for 20, 30 years, and you could be unaware. So on the angiogram, the fact that the arteries, quote unquote, look normal does not mean that you do not have atherosclerosis. Or minor plaques do not mean that you are not at risk, because they can rupture, erode, a clot can form, and you get abrupt cessation of blood supply and you get a heart attack. The second thing you got to know is when we do these tests, we are looking at the large vessels, vessels up to the diameter of about half a millimeter at the most. But there are the vast majority of blood vessels in your brain and the heart are much smaller than that. They are the arterioles and the capillaries. And you could have small vessel disease and not know it. And you could have angina because you're not supplying enough oxygen when it is needed. And the angiogram is done and it quote unquote looks normal. And the woman, it's mostly occurs in women, is told, oh, it's not your heart, don't worry about it, or they have no reason to understand why they're feeling the angina. And that is the small vessel disease. And the corollary to that is that this is why the CT angiogram, in my mind, is one of the best tests that we have in cardiology now, where we do a CT scan of the heart. It's done as an outpatient. Once they put you in the CT scanner, they inject a dye into the vein and they take the pictures and you're done. It literally takes 2 to 3 minutes. You don't even have to take your shirt off if you have no wire, bra, or anything on. And that's fine. And you can know what's going. You get off the table and you get the information. You not only get the information about the lumen, but with the CT angiogram, you get the information about the wall of the artery, the extent of the atherosclerosis, where it is located. So you get much more diagnostic information out of a CT angiogram, and you get much better prognostic information of what will happen to the patient in the future from the CT angiogram, from things like the calcium score and other parameters. So that's about vascular disease. And the same holds true in the brain and other parts of your body. Does that help?
I'm sure it does. Thank you, Alnoor. The next question is, what age is good to start statins in young South Asians in the West?
Okay, so it's all a concept of risk. If you are a 25-year-old South Asian female who is not overweight, does not smoke, does not have diabetes, but has a slightly elevated cholesterol, there is no real benefit in you taking statins because your overall risk of developing coronary disease is already very low. You can make lifestyle changes of the type that we have talked about today, and you can therefore mitigate that low risk even further. But if you are a 30-year-old male, South Asian, who has a little bit of a pot belly developing already, and your father had a heart attack at the age of 40 or 55, for example, and you have slightly high sugar, and your cholesterol is mild to moderately elevated, lifestyle alone is not going to work, because you will now need to lower your cholesterol significantly more so that you mitigate that risk that you are already carrying, which is higher. So it's all a risk benefit ratio calculation. So you go with more aggressive therapy and medications when the risk is higher, but you go with lifestyle, which always goes with every type of therapy, and you can sometimes manage without the use of medications. So if you are a homozygous hypercholesterolemic patient, which means you have a mutation on both the chromosomes, which makes you produce high cholesterol in your blood from birth, you're going to need statins at the age of 5, 6, 11, or 12. Doesn't matter. You're going to need statins, and now even the more stronger lipid lowering drugs that we have at teenage life or younger. So it is all an issue of the cholesterol issue and the risk, whether you're going to need statins. If you are a heterozygous hypercholesterolemic family member, then you need the statins in the later teenage years because you only have a mutation on one of the chromosome, not the other. So it's all a matter of how long the cholesterol risk is persisting in your bloodstream and the aggressivity with which you need to treat it. I used to treat patients in the early 80s when they were in their late 20s and 30s, and it was considered heresy. And I got a lot of negative flack from a lot of my colleagues. But a lot of those people, those patients are alive today. And now it is part of the guidelines that those people with those type of cholesterol elevations should be treated with statins. So that's the statin story. It's completely dependent on your cardiologist assessing you the right way, looking at what your risk profile is, the years that you have carried that risk, and the need to decrease that risk over a period of time, whether you need to decrease it quickly or you have time to work on it. So that's where you separate a cardiologist from a cardiologist. One who knows when to give the statin at the age of 17 and knows when to give the statin at the age of 48. That's what separates a cardiologist from a cardiologist.
Thank you. So the next question is, how many heart attacks can one person survive? How much does inflammation of the body play a role in heart attacks?
Okay, so we know, I'll tackle the inflammation part first. We know that when we treat people with statins, that we can decrease their risk. And that risk, the lower we bring down the statins, the lower we bring down the cholesterol with the use of statins, whether in primary prevention or secondary prevention, lower the risk of coronary events. So statins save lives and they prevent heart attacks. If somebody doesn't believe that today, that person is actually saying that the earth is flat. All right. How do these statins work? The statins work by lowering your cholesterol. So we looked at people who actually had low cholesterol in this range, where the cholesterol was very well controlled. But we looked at a second marker, which was a marker of inflammation, which is called CRP, C-reactive protein. And those who had a marker of high inflammation, the CRP levels were higher. And these people were then given a stronger statin. like Crestor or rosuvastatin, and they brought their LDL lower. But most importantly, they brought the CRP level down, the inflammation down. So now the plaque, which was there with cholesterol and inflammatory cells, becomes a stable plaque with less cholesterol and less inflammation, is seen by a lower level of CRP. They have an even lower rate of heart attacks and strokes or sudden death. So we know that both are important. The cholesterol lowering, the LDL cholesterol, the bad cholesterol, and lowering of the inflammation. Then we looked at studies where we just lowered the inflammation. Let the cholesterol live where it is. The Cantor study, the Lodoco study, where we used canakinumab or colchicine to lower inflammation. And these studies demonstrated that you get less heart attack and less strokes. So the inflammation is very important. It is the reason for the residual risk after you have already brought the LDL cholesterol down. Both are equally important.
Great, thank you. I will put a couple of these food questions together. One was, is desi ghee good or bad? Is air frying okay? And is frying eggs in coconut oil okay?
Okay, these are all excellent questions. And that opens the door for me to explain a few things to you. Firstly, about desi ghee. Oil primarily is a poison for the lining of your blood vessels. Oil that you adulterate. So doesn't matter if you take olive oil, if you heat it up and recook in it, it's just as bad as any other oil. So when you adulterate a natural oil, it becomes poison. But oils in general are a poison to the lining of your blood vessels. So when you take oils and then you further adulterate them by processing them and making margarine or butter or ghee, then you worsen the situation further and they become harmful. So now you're cooking in poison. And that poison is going with the most healthy foods, whether it's vegetables you're cooking or you're putting it with ice cream with fruit or something. You are adulterating the protection and you're losing the protection when you use oils to cook. And the more processed the oil, which is ghee is the worst, then worse the problem. All right. The other issue was coconut oil. So which oils are good and which oils are bad? So we know that nature has put healthy fats in our universe. And I told you about the healthy fats. And these are fats which are olive oil, avocado fats, and some of the vegetable fats which are polyunsaturated. All the tropical oils, doesn't matter which tropical oil we take, including coconut oil, are more harmful than the polyunsaturated fat. Even if you wash your hair and embalm your body every day with coconut oil, you will not escape having a heart attack. Coconut oil for cardiovascular disease is not protective. Was there another part of the question I missed?
But there was one about air frying. Is air
Oh,
frying
yes,
all right?
frying. So it's how you cook the food. Remember, I told you, sometimes you can just be on the diet that you're on and make no changes in what you eat, but make changes in when you eat and how you eat. So, how you cook is also very important. So, if you broil foods or saute foods, or you boil eggs, or you barbecue the meat, you are less likely to be harmed. But if you fry your foods or you cook your foods in a situation where there is a mixture with oil, then you're going to get into trouble. So it's about how you cook. So if you fry, it's the worst thing ever. So if you fry in the oil that has been reused and reused, McDonald's fries, it's the worst. But if you fry in oil that is only used once, it is harmful, but not as harmful. If you air fry, then you have less oil intermingling with the food during the heated process. So it is less harmful. But in the overall scheme of things, it is still very harmful to fry. We are not supposed to eat food by frying it. Okay, next.
Perfect, thank you. So I hope I can pronounce these drugs properly. If taking rosuvastatin and ezetimibe and achieving an LDL of 0.8, but HDL at 0.96, LDL is good under 1, but LDL is low at under 1. I think it's HDL. Should one be concerned about the low level of HDL, and how can one address this? I hope you got that.
Yeah, I got it. So the question is about rosuvastatin and ezetimibe. So that's Crestor and Ezetrol combined together. You produce cholesterol in your liver and multiple other organs in your body, including the ovaries and kidneys, skeletal muscle. Essentially, a large number of organs in your body produce cholesterol. So when you look at a cholesterol in your blood, LDL, which is the bad cholesterol, over 80% of it is produced in your body from other foods that you eat, fried foods and in adulterated milk and ice cream and all those things. Only 20% or less of the cholesterol in your blood comes from absorption of food. So this is why the new diets say you don't need to worry about cholesterol in your diet. It has messed up people. Yes, you don't need to worry about cholesterol itself, like eggs, because it contributes minimally to the level of blood cholesterol. But the other foods that you eat make cholesterol in your body. So 10 to 20% of cholesterol comes from absorption from your food, and 80% or so is produced in your body, primarily from the other bad foods that you eat. The way the statins work, which is rosuvastatin, the strongest statin we have, and probably the best statin we have from many points of view, and I can elaborate that later if needed. It is the best statin that you can take today, particularly for South Asians who don't do as well with Lipitor. So the cholesterol is from the production and absorption. So statins decrease the production of cholesterol in your blood. And what ezetimibe or ezetrol does, it prevents the absorption of cholesterol. So you have a dual mechanism. You decrease the production and you decrease the absorption as well. So you are in a situation now where you can bring down your cholesterol levels very low. And with this really low cholesterol levels, LDL cholesterol levels, you decrease the risk dramatically. When you are born, the Lord or whoever brought you, built you and put you into this world, whether it's evolution or creation, immaterial. The baby is born with an LDL cholesterol of 1.0. That's the cholesterol LDL you are supposed to be having for the rest of your life. Unfortunately, the way we live and our lifestyle, the westernization, all the other things, increase our LDL to higher levels. So the lower you bring down your LDL cholesterol, the better. It's impossible to get your LDL cholesterol below 1.8 or so with diet, or below 2. You need a statin or another effective medication. And to get it down to the level of 1 or 1.2, which is where regression, where actually the artery cleans out, and you have actually regression of coronary disease, is at levels around 1.0 or 1.2. To get there, you need combination therapy. At that point, the HDL is not that important because all cholesterol is decreased. So LDL goes down a lot and HDL is going to drop a little bit. That is not a problem. So you have your HDL below 1, no big deal. But you get your LDL at 1 or 1.2, you will get a dramatic benefit and you will actually get regression in your coronary artery disease. So if I can find that slide quickly, I would show it. Okay, so that's the issue of using rosuvastatin, which is Crestor, and ezetimibe together. Does that handle the whole question? Oh, here,
Yeah,
let me show you this slide. So this is looking at the plaque. This is looking at the actual hardening of the arteries inside the artery using intravascular ultrasound. And we find that when you lower your LDL cholesterol in the 100 to 120, so in the 100 to 120 range, that is in Canadian numbers, that's a LDL cholesterol of about 3.5. You still get the disease continuing to progress. The lower you bring down the LDL cholesterol, less the disease progresses. Remember, I told you it starts in young age and it is a progressive disease through life. If you have risk factors, that progression is accelerated. All right. But if you bring down your LDL cholesterol really low, below 70, which is 1.8, or in the range of 50 or 60, which is 1 or 1.2, then you actually get regression of the plaque. And that is important. But more important than that, right along this period, you have changed the consistency of the plaque and you've made it less vulnerable, less likely to cause the heart attack than if you had not brought the LDL to this level. So you start decreasing death and heart attacks at this level, and you actually reverse the atherosclerotic process at this level. And you need a medication like rosuvastatin to do that, Crestor, because it is the most effective. And 10 milligrams of rosuvastatin will do the same job as 40 milligrams of atorvastatin, which is Lipitor, as the same as 80 milligrams of Zocor, which is simvastatin. So these different statins have different potencies and different side effects.
Perfect. Thank you. The next question is, what age should one get a CT scan or even request for one?
Okay. So again, it's a situation of risk. If you have a person whose brother in Nairobi had a heart attack and passed away at the age of 45, he was quote unquote healthy before and nobody knew he had any problems, and he had a sudden death. He doesn't necessarily have to have had a massive heart attack. He could have a tiny heart attack. It's the electrical malfunction that kills them suddenly. Anyway, so if you have that situation, and you have a situation where you have a little pot belly, and you are South Asian, so just being South Asian, your arteries age 10 years faster. So if you have 40-year-old, you have the arteries of a 50-year-old. That's the easy way to remember it. So you're 40, your brother at 44 had this heart attack. You are now jolted into action. You want to say, what can I do about it? You can go into denial and be macho and forget your responsibility, not just to yourself, but to the rest of your family, and not do anything about it. Or you could be sensible and be jolted into action and say, what should I do? So now this person, what he should do is go to a doctor who knows how to understand and determine what the risk level is, what the risk pattern is. Higher the risk pattern, more intensive the investigation that you're going to require to completely accurately delineate the disease. All right. So this patient, South Asian, 40-year-old, has a little bit of pot belly. We don't know what his cholesterol is. We don't know his blood sugar. We don't know any of that. Goes to a doctor who knows how to assess risk. Usually a good cardiologist, a good internal medicine specialist, and some excellent family doctors can do that too. So he then does all your blood work and he assesses you and does your cardiogram. And he then puts all those parameters together. Now he has the information of your blood sugar. He has the information about your renal function, your creatinine, your cholesterol, your LDL, your HDL, homocysteine. He has all these information. He plugs that into what is called the Framingham equation, or there are many other risk calculators that are available on the internet, and you can do it yourself. And you can plug your age, your sex, a positive family history, not cholesterol level, blood sugar, this, that, and get a risk profile. So if that person falls into a mid or a high risk profile and is concerned enough about his heart, the best test, and I'm telling you, and I've been saying it for 10 years, that the best test for that person is a coronary CT angiogram. Not just a coronary CT scan, which just tells you the calcium score, but a coronary CT angiogram, like I described before. It's an outpatient test done in 2 minutes or 3 minutes. You just have to inject dye into the vein, bang, bang, and it's done. And you get the information. It gives you extremely diagnostic information of, do you have the disease or not? How extensive is the disease, and what is the status of all the blood vessels in all the different segments, and gives you prognostic information of what's going to happen to you in the next 5 or 10 years. And if there is a problem and now you need to do something about it, then you need to have an angiogram with which you can have an angioplasty or stent, or have the angiogram to show to the surgeon so he knows what to do during the bypass surgery. So the coronary CT angiogram is a very important test that I've been talking about for 10 years. In the last 2 years, it is now in all the guidelines in the US, Canada, and Europe, that in females who have an atypical symptom, the best test to do is a coronary CT angiogram, because it gives you the definitive answer. You can then do an exercise test or an exercise imaging test to understand the functional significance of those blockages and get the full picture, and then know how to fully assess and manage the patient. And this is what puts apart a cardiologist from a cardiologist. So I believe the one test that gives you the biggest information, the biggest bang for your buck, is the coronary CT angiogram. And who it should be done in is dependent on the baseline risk. And we learned that in the 16th century from a priest called Reverend Thomas Bayes. He said that the likelihood of something happening is dependent on the likelihood of it already happening in the first place, before you do any test or before you assess the situation any further. So if you have a moderate or high likelihood person and you do a test, it gives you a much better information of what is really there and what is going to happen, as opposed to a person who is very low likelihood of having the problem, and you do a test and the test comes out positive. It's more likely to be a false positive test, and it is going to lead you astray. So the test interpretation should always be done in the presence of the pre-test assessment, which is usually clinical. So the cardiologist who knows how to assess the pre-test likelihood knows which test to do, and therefore the result can be interpreted appropriately for that person. So Reverend Thomas Bayes in the 16th century taught us this. We now call it the Bayes Theorem. And when I did my nuclear cardiology research at UCLA, there was a cardiologist there called George Diamond and Jim Forrester, who wrote the first paper applying Bayes' theorem to medical testing. And I learned it from the masters and have used that throughout my career to understand when to do which test. First of all, which test to do, when to do it, and what does the result mean. And if somebody just shows me a test, I am useless of helping him. I have to know the information about the person. I have to know the whole person. I don't want to know the state of the disease. It's only when I know the whole person and the state of the disease that I can achieve the best results.
Perfect, thank you. I'm going to combine these two questions together, although you've already touched on the calcium score part, but let me just get to it. Is it worth getting a coronary artery calcium score? And the question, another question related to that is, how important is calcium score test?
Okay, so when you do the test that I'm talking about, coronary CT angiogram, or if you go for a calcium CT scan, it is exactly the same equipment and is done exactly the same way. The only difference with the coronary CT angiogram is you inject the dye, and the computer processing that is required to then show you the arteries and the information is different. So one ends up giving you the calcium score and a look at the arteries, whereas if you go for a calcium scan, all you get is a calcium score. And we started in this business in the late 1980s, just doing calcium scores. And then we developed a technique with the same equipment, but better computers to do coronary CT angiograms. The coronary score tells you, calcium score tells you a lot. And if you want a quick screening test, it's an excellent screening test. So if you have a calcium score of anything higher than 0, that's your risk starts to increase. It doesn't matter if the report tells you you are in the 10th percentile or the 80th percentile or the 50th percentile. It's not important to compare you to 100,000 people in the general population. What is important is your risk, the individual's risk. And the risk starts to rise as soon as you develop calcium in your arteries. You cannot develop calcium in your arteries unless you have atherosclerosis. The problem with South Asians is we can get very bad atherosclerosis. It's usually soft plaques, usually of medium degree of stenosis, lot of cheesy material, very thin fibrous caps, which means lots of vulnerable plaques, but no calcium. So the calcium score by itself can mislead and give a false sense of security to a South Asian person. Watch that. Cultural differences are very, very important. Cultural and ethnic. So ethnic is genetic contribution and cultural is lifestyle contributions. So both ethnic and cultural contributions are important in assessing patients. So the calcium score is very important as a screening test. If you have a calcium score of over 100, you're already swimming with bad fish. And if you have a calcium score of 250, you're swimming with a tank only with sharks. So just remember, it is a gradation of risk that it tells you. It doesn't tell you the problem of the disease itself, how bad it is, where it is, and the prognosis. So that's the difference between a calcium score and a calcium CT angiogram. The costs are obviously very different. So a lot of people just go for a calcium score. And if it's 0, then you're okay. If it's 250 or something, then you have to go again for a calcium CT angiogram or go for a straight angiogram, depending on your risk profile. So if I have a patient who is 45 years old and is having the symptoms of breathlessness and he feels this little burning when he exerts and then he feels better and he sometimes burps, he's not sure. And then I do a assessment and his cholesterol is a little high and his blood sugar is borderline, I am not going to waste my time doing a stress test or a coronary CT angiogram or a nuclear MIPI scan. That patient has disease. He needs to be fixed. He needs a real, proper, invasive coronary angiogram and either a stent put in, which is in certain circumstances, or go for bypass surgery if he has a certain pattern of coronary disease, which vessels are involved and where the vessels are involved. So it all depends on playing a good clinical cardiologist first and then proceeding with the testing.
Great, thank you, Alnoor. It's already 2 o'clock, and we've been going on for about 2 hours. I don't know how everybody feels about your questions because there's still a few more questions that people have asked. Diamond, Alnoor, how do you guys feel about this?
I'm happy to continue.
It's entirely up to you, Farida and Alnoor. Please feel free to continue.
Alnoor, are you okay for answering some more questions?
I
Since
think we should,
there's
because
still a few more people around. Okay,
because if
great.
we continue, which is what I would prefer,
Perfect.
if only one other person gets another 1 point of learning or an important issue that helps their life and their family members, it will be worth it.
All right, so let me just continue with the questions. Right, so if the capillaries supplying the heart shows blockage, then what is the risk of getting a heart attack in the near future?
Good. So when we do so let's say you get that information from a CT angiogram, or you get the information from a real angiogram where you have to actually put the catheter from the artery in the groin all the way to the heart, inject dye, or from the radial artery and then take the angiogram. So whichever way you get the information, you now have an idea of the blood vessels in your heart. And we are usually looking at the arteries and the smaller arteries. We're not looking at the arterioles and the capillaries, which are too small to image and visualize on any of our testing. So if the arteries show blockages, then you want to determine the risk. So I have a patient who has a 75% blockage in the left side artery and a 90% blockage in the right coronary artery, and is not very symptomatic, and his risk factor profile is such that I can bring it under total control and get his cholesterol down and get him to change, get him to understand the responsibility he has of lifestyle, and I do my responsibility with the proper lifesavers. Then I don't need to do any more. I don't need for him to have a stent or a bypass surgery, because the pattern of his coronary disease is not going to increase his risk of heart attack or death. And with good medical therapy, what we call OMT, optimal medical therapy, you can decrease the risk of a heart attack or sudden death or chronic death, which is heart pump failure death. So how do we predict that risk? We predict that risk in the totality. You don't predict the risk on the arteries alone. You predict the risk on the human being. Is the human being that's going to get a heart attack or is going to die? So I'm repeating this theme. It's the assessment of the total patient, what his family history is like, what are his risk factors, how well I've controlled the risk factors, what is his life like? Is he a pilot or is he a postman? I mean, those things all come into the picture. And it's not that the pilot is more important than the postman. It's just that when the pilot or the bus driver, who's actually worse, has a heart attack while driving the bus, the risk is dramatic on all the people in the bus. But if the pilot has a heart attack, there's usually co-pilot and there's autopilot. So the risk is not as worse. But if the postman has a heart attack delivering mail, then he or she is at big trouble himself and his family, but is not at risk to others. So all those factors have to come into play. So I can't tell you that this feature on the angiogram means 5% risk or this feature. But the Framingham tables, which you can download from the internet, or other risk factor assessment tools, and you plug in all your numbers, will give you a risk percentage of having a heart attack or dying in the next 5, in the next 10, in the next 20 years. And now there are calculators which give you the risk over a lifetime. But you got to plug in all that data. More data you plug in, the better you are at accurately predicting.
Perfect. Okay, so this person has already asked a question about the vessel disease, but I think that they may have a little bit more to ask about it. I'll read the whole thing. Thank you for responding to the question. I would like to know about the vessel disease problem in smaller arteries or vessels. How do you prevent it? The blood test does not show the person has a heart attack, but the arteries, do not show as having any blockage. Am I wrong in thinking that the vessel disease exists?
Excellent. So I'm glad the person persisted and took the question to a higher level. So what is important to the heart muscle is to be able to get blood and oxygen. And it gets that from the capillaries and the small vessels, which we do not see on a CT angiogram or on a regular angiogram, the imaging we do. And they can have disease in these small vessels, which we call small vessel disease, and in the smaller vessels than that, and the oxygen will not reach to the myocardium, and the person could be having angina. This is more common a situation in females, and this situation is now called NOCA, non-obstructive coronary disease or coronary angina, non-obstructive coronary arteries, and the patient's having an angina or still having a heart attack. So what is happening is that the arteries that you're looking at, quote unquote, look normal. But the myocardium is not getting enough oxygen. The perfusion is down. So you want to do a test where you assess the perfusion. You let the test work in such a way that whatever you are injecting or whatever you're doing is giving you an idea of the flow of blood inside the muscle of the artery through those small arteries and capillaries. So you want to look at the perfusion, not the garden hose, but the garden hose that's stuck into the ground. And now 5 feet further, you want to know how much water has reached there through the soil. Well, thank you for giving me the opportunity to tell you that I was one of the first people to devise that test. In those days, that was my research at UCLA, funded by the Aga Khan Foundation from Geneva, and that opened the field of what we now call nuclear cardiology. And in those days, we used to do this test, and we used to call it thallium test. We exercised the patient, injected radioactive thallium-201. It went wherever the blood went. So it would go into the heart muscle, and it would perfuse into the muscle based on the blood supply. So whether you had a blockage in the main artery or whether you had blockages in the small arteries, it would not perfuse into that segment of the heart muscle. So then if I was able to then use a Geiger counter that detects radiation in the form of an Anger camera, which is a nuclear camera, to image the heart, and there will be certain part of the heart that will not have enough radioactivity, and certain part of the heart, other parts of the heart which have normal perfusion will have good radioactivity. I'll be able to detect the discrepancy in flow related to perfusion, whether it is big artery blockage or small artery blockage. That opened the whole field of nuclear cardiology, and I wrote some of the earliest papers validating this technique and using this technique to detect myocardial ischemia and high-risk coronary disease, where you can actually make an impact to the prognosis. That test got refined as the years went by. We, instead of just imaging with stagnant cameras, we started imaging with a rotating camera. So we got tomographic images. So instead of taking a picture of the apple, we are now able to slice the apple and look at every slice. Obviously, we get more information. So we went from that planar imaging to tomographic imaging, and then we went from using thallium-201 to a different isotope using technetium-99m. So that technetium-99m chemical is called sestamib, and now we call that test MIBI-scan. It all started from our work at UCLA Cedars-Sinai Medical Center, where we did this in humans and validated it and showed the importance of this test to detect perfusion. So the person who has symptoms very similar to angina, but the coronary arteries, quote unquote, look normal, the nuclear scan, the MIBI scan, can show that it is abnormal and that the person has small vessel disease. And the prognosis is bad of people who have this type of small vessel, and they can get heart attacks. So this is the situation that we used to call women having heart attacks or women having angina, but their arteries are normal, so something's wrong with them. No, it occurs in men as well, more in women. But what it is we weren't able to understand what we call NOCA disease, which is non-obstructive coronary artery disease, which is usually related to spasm or small vessel disease. Does that answer it further?
I hope it does. It's just pretty extensive. Anyway, so I'm going to go ahead with a couple more questions. I'm going to combine these two. What is the alternative treatment for a person who cannot tolerate statin drug due to muscle cramps and pain? And does taking statin on alternate days help? And the second part to this other question is, what can you do if you are getting muscle or weakness when taking statins?
Okay, this is an excellent question, and it occurs all the time. And this is a situation that we try to handle all the time. So we know that statins are the most effective medications that we have available to decrease the risk of a heart attack and decrease mortality. Without a question, no problem. Now you have people who cannot get their cholesterol down enough with statins, or that they are unable to tolerate the statins at full dose, or that they are unable to tolerate statins at all. What do we do for that? So we started into the era of looking at combination therapy using smaller doses of statins and cholesterol absorbing drug ezetimibe that I've already told you about. And we tried various combinations, statins and bile sequestrants, PPAR agonists, fish oils, niacin, CTEP inhibitors. And of all these combinations, what has worked out the best and has shown that you can decrease heart attack and death is the addition of ezetrol to statins. So if you are unable to take full dose statins, you can take a lower dose statin or switch the statin to a different type, which may not give you as much muscle aches and pains. And with the ezetimibe, a 10 milligram of Crestor works as well as a 40 milligrams of Crestor, because it brings down the LDL in combination that well. And that is primarily because you're working at the absorption and the production site. So we realized that we had a situation where people could not tolerate statins at all for whatever reason, and we still needed to bring down their cholesterol, or they were taking the full dose of statin and we still weren't able to get the LDL below 1.8 or at 1.0 where we really wanted it. We developed a drug, the drug's called PCSK9 inhibitors. Without going into too much detail, PCSK9 prevents the LDL receptors to regenerate and clear the cholesterol. So when you have PCSK9, you don't clear your cholesterol. So if you inhibit the PCSK9, you make your LDL receptors work better, and you clear the cholesterol better. And we found that these monoclonal antibodies were extremely effective in lowering your cholesterol in combination with statin or used alone. And you're looking at a person who's been taking PCSK9 inhibitor for the last 5 years, the earliest person in Canada who started taking it outside of a research trial, and my LDL cholesterol is 0.8. So, but my situation is very different, so not everybody needs to take it. So we developed these new substances called PCSK9 inhibitors. Well, we then said, if you can inhibit the PCSK9 inhibitor, why don't you prevent the production of PCSK9 to begin with? So the LDL receptors are going to be flourishing on the surface of the liver cell and clearing out your cholesterol perfectly. So we developed this small vessel mRNA peptide, which is inclisiran. And what this small RNA peptide, messenger RNA peptide does is it gets into the liver cell because it is produced in such a way that it has an affinity for the liver cell. So it doesn't go into your eye, it doesn't go into your ovary, it's just going to go primarily into your liver where we need the action. So now we have developed selectivity. With the PCSK9 inhibitors and the statins, we did not have selectivity. They went everywhere and did everything everywhere. All right. So with the messenger RNA small peptide molecule, inclisiran, we now have liver specificity. And at the same time, what it does inside the liver is mess up the messenger RNA, which is supposed to make the PCSK9 molecule. So now you completely drop the PCSK9 production and you get LDL receptors flourishing and clearing your cholesterol. So the beauty of the PCSK9 inhibitors, they are monoclonal antibodies, so you can't take them as a tablet because the peptide monoclonal antibody is digested in the stomach and it dies. So you have to give it as an injection. And I'm not sure if you know what these injectors are like. I wish I had one nearby I could have shown you. It just basically looks like a ballpoint pen, and you just put it on your thigh or on your arm, wherever you want to go, and you just press the ballpoint pen like that. You don't feel the needle, and all it does, it injects the PCSK9 into your system, and you don't need to take another injection for a month, and it works. So this is my injector. I just take that off, I put that there, I press this, and it and it shows the and it injects the thing. Farida, can you still see me?
Yes, I can see you, but I think somebody is sharing their screen. I'm not sure who they are.
If they could please go off the screen, that would help. Okay.
Thank you.
So can you see my screen now?
Yes, sure.
Okay. Now, the beauty of inclisiran, the messenger RNA mess-upper, is that you need to take this tiny injection where you don't feel the needle. So there is actually a color thing that goes in there, so you know that it has all gone in because you don't feel the pain. Or the clicker actually clicks again, then you know the medication has gone in. Once every 6 months. That's it. You take the little thing, and for 6 months, you don't have to take any pill or any injection or any tablet or nothing. And how effective it is, it absolutely knocks out the PCSK9. It absolutely drops your cholesterol level and keeps it low for the 6 months until you take your second injection. Immunization, once every year or twice a year, hurts 10 times or much less than a flu shot. So we have these better drugs that are more effective now. We have now a new statin-like drug, which is bempedoic acid, which works by decreasing the production of cholesterol in the liver, very much like a statin. So we have many other ways now of handling patients who cannot take statins, or they do not get enough lowering of their cholesterol with statin alone. So there are three issues with statins that always come up. One, side effects. muscle aches and pains, and people worry about liver damage and kidney damage and all kinds of things. First of all, yes, it is true that statins do cause muscle aches and pains. They do not cause cramps. The cramps that you feel in your calf muscle or your thigh or somewhere in the night or at other time is not related to statin. Statin flows all over your body and is basically going to be giving you a side effect in all the muscles of the body. And where you feel them most are your proximal muscles around your shoulders and back and around your hips and thighs. So if you have aches and pains in your joints or in one particular area of your body or the other, it is not due to statins. Point number two, the real severe muscle damage that occurs with statins, which is called rhabdomyolysis, occurs in 0.001% of people. A higher risk when you drive from Don Mills to downtown Toronto General Hospital, or more risk if you drive from North Shore to Yaletown in your car. So extremely low risk of this rhabdomyolysis. It immediately reverses when the statin is stopped, and deaths are extremely rare. And we now have also learned what are the types of patients who are at risk of this rhabdomyolysis, and we don't give them statins to those patients, or we take off this other drug like a fibrate and then give them the statin. So you don't get the drug to drug interaction or drug to supplement reaction, which sometimes causes the trouble, the supplements people are taking, and causes the rhabdomyolysis. So that's about the muscle aches and pains. About 5% or 10% of people get it. It's easily manageable by giving a drug-free period and restarting at a lower dose, or giving it twice a week and then upping it to 3 or 6 times a week and working that way, or switching the statin from Zocor to Mevacor to maybe Lipitor to Crestor, and so others are tolerable. The second concern with statins is they cause diabetes. This is the problem with the press. When you are assessing these drugs in thousands of patients, like statins have been assessed in, there are patients in that group who are pre-diabetic. And over a period of 3 to 4 to 5 years, as we are tracking these patients on statins, they are going to develop their diabetes. So the statin did not cause their diabetes. They were going to get that diabetes anyway. Statin is a coincidental association, not a causal association of the development of diabetes. It's just the diabetes, which was pre-diabetic, has unmasked into real diabetics. And the third concern that a lot of people have is if we lower the LDL cholesterol extremely low to lower than 1, very low cholesterol levels can cause cognitive dysfunction or dementia. Not true at all. Now that we have drugs such as PCSK9 inhibitors and inclisiran, we can drop the LDL cholesterol to 0.6 from 3.5 or 4.5. These patients have just as good a cognitive function as they had when they started. However, as they get older, they get less dementia and less cognitive dysfunction, because primarily the commonest form of dementia and cognitive dysfunction is small vessel disease in the brain, and statins prevent that through the process of atherosclerosis. So does that help?
That was pretty conclusive. Thank you. I just wanted to mention a couple of things. We only had this session for 2.5 hours, so if we get cut off, that'll be the end of it. But we are trying to extend it. But so I will continue with the next question. And if you get cut off, I'm sorry about it, that all your questions were not answered. But, Alnoor, everybody has been very impressed with your, talk and your presentation and your answering of all the questions. So let me continue with the next question, and I hope we can continue. But if not, then, thank you so much for being present and doing such a great job, Alnoor. So here's the next question.
In my privilege.
If you have had valve replacements and there is damage to kidneys and liver, do the statins cause further damage that requires extra monitoring?
Excellent question, because people have other cardiovascular diseases, right? So once you have a valve disease, or you have cardiomyopathy, or you have kidney disease, you are more likely to develop atherosclerosis. And the last thing you want is a patient whose valve is leaking and the pump is failing, the heart pump, and give these people also a heart attack. I mean, that's the last thing they need. So you want to use statins and other medications in these people, control their diabetes with the right kind of drugs. There are 5 or 6 different kinds of classes of medications that all bring down blood sugar, but only 2 classes of diabetic drugs actually decrease the risk of heart attack or strokes or death. So you have to do the things with the right medication, not just important to lower the blood sugar or lower the cholesterol. How you do it with which drug is equally important. So in those people, you don't want to have a heart attack when they already have a cardiovascular problem. So you want to use the statins, but then you're worried, will the statins cause a problem with the kidney? This problem has been studied ad nauseum. Thousands and thousands of patients with mild, moderate, or even on dialysis have been treated with statins without worsening their renal function. And in many cases, improving their renal function if the renal function is due to a vascular disease, by preventing progression of the vascular disease from the causing more kidney damage. So statins can be used, but you need to monitor. You need to monitor particularly in patients who are at risk of rhabdomyolysis. Now that, I think most cardiologists go through their whole career and don't see 2 patients who are at that risk of rhabdomyolysis. They are rare. There are people who take immunosuppressive drugs and have atherosclerosis and have a particular enzyme elevation in the liver, are at some risk. So just remember, these are rare situations. So by and large, you don't need to monitor the liver function or the muscle enzymes. All the guidelines now have taken away the need to monitor your liver function or your muscle enzymes when you put people on statin therapy, except the people who have what is called non-alcoholic liver disease, NALD, where you get fatty liver infiltration and the person is not an alcoholic. This non-alcoholic liver disease worsens with statins. And so the enzymes will go up. And in that situation, you need to monitor. Or if you have a person who is at risk of rhabdomyolysis, that rare patient, and you are a cardiologist who has been able to recognize that patient, then you need to monitor the muscle enzymes. So you can use the statins in people with kidney dysfunction, in people with valve disease, with people with certain kinds of liver dysfunction, and not have to worry about it. But monitoring is required in certain subgroups.
Thank you. Can existing plaque in arteries be cleaned with medicine, or can it only stop from increasing further?
Okay, so by and large, once you have atherosclerosis, fat being deposited in your arteries when you are 16 years old or 22 years old, that process is progressive. And with age, it keeps getting worse. If you have risk factors, you accelerate the progression. So if you have excellent control of your risk factors, or if you follow my secret S program, then you don't get the atherosclerosis in the first place, then the plaque doesn't develop or stops progressing. Or if you lower your LDL cholesterol enough, then you get regression of the plaque. That's possible. But long before that regression happens, you change the consistency of the plaque and you stop having heart attacks. Within a month or 2 of starting statins, you're already decreasing your risk of a heart attack or sudden death. But atherosclerosis process takes months or years to alter. So yes, you can regress the plaque, but in order to do that, once you are an adult, you need to get your LDL cholesterol level way below 1.2. 1.4, 1.2, 1.0 is even better. Lower the better. And at that levels, not only do you change the consistency of the plaque that you don't get heart attack, but you actually cause regression of the plaque. Stop progression and actually start getting regression. Now, in order to do that, there is no human being on earth, no matter how much fasting he does or she does, that can get your LDL cholesterol to that level. The only way to do it, once you have atherosclerosis or you have that problem, you have to get super aggressive to get the LDL cholesterol down to that level. And the only ways we know, and at the present time, I will say it again, the safest and the most effective way is statin. And now we have other agents that do excellent job in combination or instead of, that can get us down to that level. So if you want to reverse the process and you are already an adult, you're going to need dramatic lowering of LDL, which will require medications. If you are a 7, 8-year-old grandson, you tell him or her to follow my secret program. Is 14 or 15, he will not get the fatty deposition. When he's 25, there will be no raised plaques in his arteries, and he will never get the problem to begin with, which is called primordial prevention. That's where lifestyle works. But once you're an adult, to get your LDL down to that level, yes, you need lifestyle changes, but you need the lifesavers as well.
Great. Do nutritional supplements have any benefits such as omega-3?
Okay, I hope I can find that slide very quickly and show you, because this is probably the most important question at the moment that asked today. And this is what the future of lipid lowering is going. It's going in the direction of omega-3. And first of all, we know that populations that eat a lot of seafood tend to have much lower levels of coronary disease or cardiovascular death rate. We also know that the compound that is in fish, and it is in the fast swimming fishes on the surface swimmers who have that fatty acid, which we call omega-3, 6 fatty acid, the EPA and the DHA. So people started to purify EHA and EPA and DHA, which is omega-3 and omega-6, and started to produce it in capsules and started to give us. And our grandmothers knew a little better. They gave us cod liver oil to drink, teaspoons of it, which was a little bit fresher. So some of the goodness was retained, but most of it was useless. But the omega-3, 6 capsules were totally useless. And major studies have been done looking at people who are getting it and placebo tablets, so both the doctor and the patients don't know what they're taking, with no difference in heart attack or death rate down the line. So what is this omega-3 or 6 story? So then we began to realize that the DHA in the fish oils, the omega-6, actually counteracts the benefit of omega-3, which is EPA. So then when we give EPA capsules, which is omega-3 alone, then it does not raise the level of EPA in your blood enough to be able to achieve that benefit. So it's only when you raise the EPA level, whether it's in the strength trial, JELIS trial, or now the latest reduce it trial, that you actually decrease heart attacks and decrease death, improve the survival. So now we realize that omega-3 is protective, that we had always thought was so from fish. Omega-6 is not, and worsens and counteracts the positive effect of omega-3. And now we know that it only works when you can raise the blood level of omega-3 to pharmacological levels, not just with dietary changes. Dietary changes from birth of eating seafood is excellent, but when you're an adult, it's not going to be enough. So we have now got a drug called Vasipa, which is icosapent-ethyl. And what icosapent-ethyl does, which is IPE, is it increases the level of EPA in your blood naturally. So you make your own effective EPA in your blood. So now, if you can raise it enough by giving you this icosapent-ethyl fish oil at large doses, 4 grams twice a day, which is now supplement. So now we're giving fish oil supplement, which is the same as taking other supplements, but this one does the special thing of raising your EPA level naturally inside your body. You stop having heart attacks and strokes, even after you've been on the best statin therapy. So we took patients in the Reduce It trial who had excellent LDL cholesterol levels, even who were on statin therapy, but they were still having heart attacks and strokes because statin does not completely take away the residual risk. There is still the residual risk that occurs even after statin therapy. So these patients who were given Vasipa, which is icosapent-ethyl, on top of statin therapy, which is all the patients in these trials, they found that you could lower the heart attack rate and the death rate even further on top of statins. So they say, who are these patients who are getting this benefit? And they found that patients who have the other kind of fat, triglyceride, if that is elevated and the statin is bringing down the LDL, but still there is elevation of triglyceride, and you give them Vasipa, the fish oil, then it lowers the triglyceride and it decreases their heart attack and death rate. But we also found that regardless of the triglyceride level, even when you give Vasipa, it works through another mechanism of helping with the inflammation. Remember, I told you the other pathway, that it lowers the risk in addition to statin. It is the best and the most advanced that we have had in lipid management since the statins is the administration of fish oil. Now, as a pharmacological drug at doses, pharmacological levels of the perfect, accurate type of fish oil, which then goes in and makes EPA in your body, which protects you on top of the statins. That help?
I'm sure it does. So this is a food-related question. Is reheating the leftovers make the food toxic or lower the nutritional value?
That's a difficult question to answer. And in cardiovascular terms, I must tell you, I cannot give you an answer based on evidence. So anything I'll tell you will be my opinion. Up to this point, I've basically told you everything where we have evidence for it. So I don't know of any evidence that shows that leftover foods or so can have a different impact on cardiovascular disease. I'm sure the food gets processed and there's chemicals developing and things happen, and that may have an impact on your gut and your gut bacteria or some other system. But I do not know the answer to that. But I'm so glad that someone asked this question, because it is a segue into something that I think is very important about statins. So statins were developed in the early 80s, late 70s and early 80s from Chinese medicine, which used to use red yeast extract to give it to people, and they lived longer. This red yeast extract was the juice of the fungus that fermented the rice, the regular rice. So the rice wasn't red, the fungus grew on it, so you had rotten rice. It fermented the starch, made alcohol, and made this other chemical. And when ancient Chinese medicine found that if they fed people red rice, it becomes red because this fungus is a purple, a reddish purple color. So they gave red rice, then they lived longer. Then they said, well, we'll give them red rice extract. So they had to have less of it, and they had that chemical in it, and they did well. So in the late 70s, Merck was experimenting with different medications to lower cholesterol, and they knew this red rice story. So what they did was they looked at what was that chemical that was the rotten byproduct of fungus growing on good rice, making it rotten rice, and actually ended up saving lives. So this rotten chemical, they say they isolated it, and then they made it generic. They chemically produced it as a clean format. Do you know what that chemical and that format that they, the chemical product that they made? That was lovastatin, the first statin medication. I wrote the prescription for that medication, the first doctor in Canada to write the prescription for lovastatin to help cardiovascular care in the early 80s. The reason I was able to do that, I was part of the research program with Merck that was looking at the use of this drug, lovastatin, which we used to call Mevacor. And so in my trial, I had these patients with very high cholesterol levels, some with familial hypercholesterolemia. So as soon as the drug became licensed, I was able to write the first prescription. And that person is today on this Zoom call, and she's still alive, has not had a heart attack, never entered the hospital for a heart problem, and was quite young, in her late 20s or early 30s when I prescribed that drug to her. And you cannot believe the amount of flack I took at that time for that. So we know that when rice becomes rotten, something good can happen if the right species of fungus grow on it. Now, coming back to the food that is, from a day before or 2 days before, whether it ferments or that, there is no evidence and there's no literature, and I don't know of anything that it is beneficial. And my gut feeling tells me, and the gut is not well designed for thought, but anyway, my gut feeling tells me that it has to be harmful to you in some way, because what we know is when food particles are stuck in your mouth after you've finished eating, between your teeth and around your gums, there is gingivitis that develops. And whatever chemical is released due to that gingivitis significantly increases your risk of atherosclerosis and coronary artery disease. And now there is evidence to show it also increases the risk of cancer. So whatever happens with food sitting around in your mouth, and the bacteria in your mouth work on it, whatever is produced is atherogenic and a killer. So if you say to me, what are the cardiovascular risk factors? I'll say high blood pressure, high cholesterol, inactivity, smoking, and I'll say bad dental hygiene, which is also a significant risk factor. So when food rots, something bad is happening from that data, and that has been scientifically proven and shown. So I don't know if the food is kept outside the fridge for 2 days and you eat it. I would think it's not good.
Right. So the next question is, what about apixaban? APIXABAN?
Yes. Right. And rivaroxaban and these other drugs. Okay. So you know that trouble occurs in the arteries of our body if they develop clots. The arteries are supposed to be open and blood is supposed to flow through them. So if you are forming excessive clots, then you are in trouble. That's one of the ways COVID, by the way, kills you, is blocking off your arteries to the heart and lungs and everywhere with clots. I was hoping to go through this whole presentation without using the word COVID, but I failed. Anyway, so because this clotting process is bad, then we use blood thinners, which are called anticoagulants. And there are two classes of blood thinners. The one class, which is antiplatelets, because we know the initial clot is a white clot formed by clumping of the platelets as soon as there's erosion. And that clumping of the platelets then forms fibrin that then traps the red cells and becomes a red clot. So to stop that initial white clot from forming, we use antiplatelet agents, aspirin, ticagrelor, which is Brilinta, prasugrel, all these newer antiplatelet agents. But to stop the red clot is a clotting mechanism, which is separate in the body. And that's job of that clotting mechanism is if you shave and you nick yourself, you're not going to bleed to death. You're going to form a clot and it's going to stop. But if you are on these different kind of blood thinner clotting, preventing the clot from forming, you could bleed a lot. So if you use it in the wrong person, in the wrong dose or something, you could cause a problem. So these blood clot stopping drugs were essentially drugs that we used to treat plague. So when we had the plague, we found out that it was transmitted by rats. So we say, if we kill the rats, we are going to not get the plague spreading. So to kill the rats, we gave them this, we put this thing in their food, cheese or whatever there was around that the rats ate that had this blood thinning medicine in it. So when they ate it, they bled to death, and so rats died. So that's why it is called rat poison. And that is warfarin or Coumadin. So we refined it, made it into a tablet, and called it warfarin. Now, warfarin or Coumadin, the trade name, has many problems with it. It's not an easy drug to use to stop the clotting, and it has to be used so that it is in just the right range in your blood. If you use too much, you're going to bleed. If you use too little, you're going to go ahead and clot. That window of therapeutic window is very narrow. So then we say, let's develop different drugs that stop that clotting process, that work differently than warfarin. So we developed these drugs called bands, apixaban, rivaroxaban. All the bands work in a different way to stop that clot. So if you want to prevent the blood from clotting, you use these newer anticoagulant agents, right? They're called NOACs, newer oral anticoagulant agents, NOACs. They work differently. They have a much better therapeutic window, less risk of bleeding, and you can keep them in the therapeutic range much better. So rivaroxaban or apixaban is one of those drugs. It works like warfarin, but is safer and better than warfarin. And it has shown to be decreasing the risk of clot and strokes from clots flying off into your circulation, going into your brain, much better than warfarin. So oftentimes now we use apixaban, rivaroxaban for patients who we want to stop the clotting, who are at high risk of clot, who have a clot in their heart, or who have atrial fibrillation or something like that. Or they have COVID, and these drugs are used in that situation to prevent the clotting. So those are the red blood clotting drugs. Aspirin, ticagrelor, prasugrel, all of those are antiplatelet drugs, and they work that way. So the two can be synergistic, and so we can use in combination but you increase the risk of bleeding. And you have to know when to use it in combination, how to use it in combination, and which of the antiplatelets to use with which of the newer anticoagulation agents, or with the older one, warfarin. That puts apart a cardiologist from a cardiologist. Does that cover the question? Or if it didn't, did I miss some part of it?
I think that should be, yeah, they covered it. The next question is, we know that during severe SARS-CoV-2 infection, heart function may decrease in this. Is this true? And if yes, then what should one do? And in that same vein, during the coronavirus stress, is it up to how does one deal with cardiomyopathy or viral infection?
Okay. I knew one way or the other I was going to get dragged into COVID. So COVID kills with many different ways, but ultimately, it's your lungs and your heart that lead to the trouble of you dying. And I showed you that slide of the individual patient level problem, where it's either the blockages of the arteries, or the electrical malfunction, or the pump malfunction. So what COVID does is not by atherosclerosis, but very quickly, within a few days or within hours, it will get into the smaller blood vessels in your heart and in your lungs and start clogging them up, because it increases the clotting. It can then cause an electrical malfunction in your heart and cause an arrhythmia, and you could die from the arrhythmia if it is a ventricular fibrillation or an arrhythmia like that. Mostly what it does, it blocks off the small blood vessels in your artery. Remember, we call that small vessel disease? And then your pump does not work well, because diffusely the myocardium is not getting perfusion. So it cannot do its work. So the heart starts to fail. It doesn't stop. Heart failure means it's unable to pump enough blood that the body needs, and the blood starts to back up. So it backs up in your lungs and backs up in your liver and in your legs, and you get swollen legs or short of breath and fluid in your lungs. So that's how COVID kills. It kills by arrhythmias, and it kills by pump failure. But the pathogenesis or the pathophysiology is through clogging up the small blood vessels.
Perfect. There's another statin question, but I think that you've gone into statins quite extensively, so it's probably, answered this person's question. I hope it has. So the next question is, does apple cider vinegar help to clear cholesterol?
Okay. People talk about all kinds of things: garlic, turmeric, and apple cider. All kinds of things. So if you want to eat rotten rice with that specific fungus growing on it, yes, you will lower your cholesterol. But if you want to lower it enough, it's not going to do it. Yes, if you eat 2 pounds of garlic every day, or 7 tablespoons of turmeric, you're going to lower your cholesterol, but not enough to do it. So you go on the internet, it shows you a study that took garlic, that took turmeric, or apple cider vinegar or whatever, and the cholesterol came down. That's a surrogate marker. That's a surrogate endpoint. It lowered the cholesterol. What you want is the real outcome endpoint. Did you live longer? Did you not get a heart attack? Did you not get a stroke? Those are called real hard outcomes. None of these drugs, none of these supplements, garlic, turmeric, apple cider, God knows what, none of them have shown enough efficacy to lower your cholesterol to any significant degree, to be of any benefit to you. All it does is you spend your money, take those things, it goes out in your urine, and you have a very rich urine going into the toilet without doing anything to let you live longer, unless you take that fungus, which is a specific fungus, and then what you are really taking is a statin. All right. So apple cider vinegar, there must be somebody out there, some naturopath or somebody who gave it to some number of people and showed a drop in cholesterol. There is no study today that has clearly shown in a randomized, double-blinded manner that any of these supplements let you live longer or get less heart attacks. That doesn't mean that there are no superfoods. There are lots of superfoods which have that phytosterols and which have the flavonoids and which have the antioxidants, and they protect you when you eat the bad foods, which is there. Those are the protective foods. So they don't go actually lower your cholesterol. What they do is when you have the foods that make cholesterol, they protect you from yourself, from your bad habits, right? So those are called superfoods. And there are many, many of those superfoods that are there.
Right. So is elevated triglycerides an independent factor?
The quick answer is yes. And do we have evidence? And the answer is yes. So I can show you the study. But the point is that all kinds of fats, and there are many, many different kinds of fats. And not cholesterol is just a combination of multiple different kinds of fats, and so is LDL, and so is triglyceride. They're just a multiple different kinds of fats. And what happens with these is that they almost all of them are atherogenic. Some are more atherogenic than others. For example, LDL is way more atherogenic than VLDL, low density lipoprotein, more atherogenic than very low density lipoprotein. And when you look at chylomicrons, which is essentially fat, essentially triglyceride, it is less, but they're all atherogenic to a certain extent. And there's a particle called LP little a, which is a lipoprotein, which is even more atherogenic than LDL cholesterol. It is only genetically determined, and darker your skin color, more the likely you are to make LP little a. And so South Asians and Blacks have higher incidence of elevated LP little a level. That's one of the mechanisms of South Asian disease. So all the lipoproteins are different, and triglyceride is one of them. We know from early on that high triglyceride increases the risk of cardiovascular disease. We had never been able to show that lowering triglyceride, whether it is with niacin or whether it is with fibrates or whether it is with any other medication or dietary measure, has lowered the hard outcomes, which is death and heart attacks, until Vasipa came along last year, which is icosapent ethyl, which is a form of fish oil, which then raises the EPA in your blood, lowers the triglyceride, and decreases your risk. So one side of the coin, we know forever that high triglycerides increase your risk over and above just the cholesterol elevation, but not as bad as cholesterol elevation. And we have never been able to prove that lowering triglyceride improves the risk. Until last year, with the Reduce It trials, we have now been able to show that it's not just the question of reducing triglyceride, it's the question of how you reduce it. And you're getting this theme in cardiology. It's not just good enough to give this medication to lower the blood sugar, or give this medication to control the blood pressure, or give this medication to lower the cholesterol or the triglyceride. It's which medication and how you use it is the real reason how you decrease the risk, not just the surrogate endpoint, which is a blood sugar or triglyceride or LDL cholesterol or whatever other surrogate endpoint is. It's the real outcome endpoints that matter.
Right. To protect heart failure further, is Zestril helpful with atenolol or some other medicine needed?
So atenolol, I know, I understand what they're saying. What was the other drug? I missed that, sorry.
Zestril. Zestril.
Zestril, oh yes, it's an ACE inhibitor. Okay, excellent, excellent question. It opens the door for me to talk to you about the lifesavers for heart failure, the pump failure. So now we are talking about a situation where the pump is failing. All right. So now we need to give medications that will prevent the pump from failing or improve the function of the pump, and will it make the patient live longer? So the end game is always, is the patient going to live longer, is going to have less disability. So we are now comparing Zestril, which is an ACE inhibitor, to the other drug. Help me again.
Um, sorry, Zestril and atenolol.
Ethanol, which is a beta
Yeah,
blocker.
yeah,
So
beta blocker.
this was the first class of medications used in heart failure in the mid and late 70s, where the person had a heart attack and we gave them a beta blocker, which was actually contra to all the thinking that we had at that time. And we realized that patients who got the beta blocker actually lived more because the beta blocker prevented that electrical malfunction of the arrhythmia. But when we looked at them 3, 4, 5 years down the line, they also lived longer and developed less heart failure because they improved pump function. So we begin to find the first class of drugs that not only decrease death by electrical means, but decrease death by pump function preservation. All right. So then that started the era of classes of drugs that would improve pump function. And the next era of drugs which came about were the ACE inhibitors, which are Zestril, perindopril, lisinopril, all the prils, which, capoten and you know, all the ACE inhibitor trade names that are not coming straight in my mind at the moment. Anyway, so this ACE inhibitor class of drugs, of which Zestril is one of them, lisinopril, and the other one is telmisartan, like Diovan. These drugs showed that patients who had heart failure lived longer and actually improved their pump function and actually had much better survival. So we found a second set of class of drugs, beta blocker to ACE inhibitors, that showed improvement in pump function and longevity. So then came along the angiotensin receptor blockers because ACE inhibitors had some side effects. And then we started using the angiotensin receptor blockers, which basically did what the ACE inhibitors did without the side effects of cough and other types of side effects. So then we had this other class of lifesavers for heart failure. Then we went along and began to find that this inhibition of the sympathetic nervous system through the renin-angiotensin-aldosterone system that these drugs work on, that you could actually impact that with another inhibitor of another chemical in that system, which is neprilysin. So then we developed the neprilysin inhibitors, and we developed a combination of an angiotensin receptor blocker and a neprilysin inhibitor. And now those class of drugs is called ARNI, angiotensin receptor blockers and neprilysin inhibitors. So we developed the ARNIs. So then over the last year or two or three, we found that patients who were treated with a diabetic drug, a class of diabetic drugs called the SGLT2 inhibitors, that they actually had less heart failure. And if they had heart failure, they actually improved and lived longer. So here was a drug we used for the surrogate endpoint to lower blood sugar And then we found that actually these diabetic patients, who essentially all die of cardiovascular disease, heart attack and strokes and kidney failure, which are all vascular diseases, that they actually live longer. So we figured out that it is not the surrogate endpoint of blood sugar, but something else that the SGLT2 inhibitors do, which preserve pump function or improve pump function and live longer. So we have now developed what are called the foundational classes of drugs that are required in patients who have heart failure. And so we have the beta blockers, of which atenolol is one of them, which was the question. We have the ACE inhibitors, which is one of them is Zestril, which is the question. Then we have the angiotensin receptor blockers, drugs like Micardis, telmisartan. Then we have the ARNIs, the angiotensin receptor neprilysin inhibitors, sacubitril. Then we have the SGLT2 group of drugs, which is like Jardians, which we use for diabetes. And these are now called foundational therapies for heart failure. What did we learn next? We learned that it's not good enough to just use one drug or this class of drug or just this class of drug. We developed additive benefit when we use a drug in this class and a drug in this class. We could give it at lower dose, less side effect, and double the benefit. So that came the era of combination drug therapies in heart failure, and the use of atenolol, which is a beta blocker, with the use of Zestril, which is an ACE inhibitor, is one of those combinations. And we have now found that adding on 1, 2, 3, 4, and now 5 class of drugs actually continues to improve survival further and further beyond the therapies that we have used. So we went from a high mortality rate of heart failure after a big heart attack to lower, 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 and lower mortality rate using this foundational class of drugs. And what puts a cardiologist apart from another cardiologist is to know which class of drugs to start with in heart failure based on the clinical situation of the patient and the underlying disease, know how to use it in which dose, how to increase the dose, figure out which combination to put, and which should be the sequence of combination to put these drugs into play, and the timing of when you add these drugs in sequence. And when you do all of that right, a lot of the patients live very long and do very well. The mother of my children's babysitter saw me in the early 80s in Sudbury when I was practicing there. And we used an ACE inhibitor when every one of her doctors had told her that it was contraindicated. And she lived for decades after that because of the right combination and the right drug used at the right time. So the use of atenolol and Zestril is an excellent combination for heart failure. But it all depends on whether the heart failure is due to ischemic disease, then beta blocker and ACE inhibitor is better, or the heart failure is due to valve leaking and valve failure and the pump fails, then the ACE inhibitor and the neprilysin inhibitor, or the ACE inhibitor and the SGLT2 inhibitor would be a better combination. So that is the trick of being a clinical cardiologist that started with William Osler, the Canadian physician.
Thank you. So how can a person get a CT angiogram test in Canada, especially BC, and can a family doctor request one?
Okay, so the problem with universal healthcare and socialized medicine is that sometimes you can't get the tests you want because there are policies and protocols and pathways of if you have this, if you don't have this, then if you did this, then you can get this drug or you can get this test. That's one of the difficulties of socialized medicine. And the other is the timely access to healthcare. So coronary CT angiogram is one of those things. It's an extremely effective test and gives you incredibly good information and can guide your treatment of that patient for the next 40 years. The problem is the cost of it and the difficulty of getting it done in the hospitals, because our socialized medicine has not allowed private labs to do this. Whereas in the US, you just go to a private lab and get it done. So there are some private labs in BC that do that. The problem is quality of the test. And second is the cost. Because there are very few private labs in Canada that do that, the cost is much higher. The cost in the US actually paradoxically is lower because there are so many labs that are getting you a coronary CT angio. So unfortunately, we live in Canada and we have this healthcare system. How do you do it? The first thing has to happen from your family doctor level, who has to recognize that you are at high risk or that you are able to convince him. And how can you convince him? You say that I wasted my whole Saturday morning listening to this guy who went on. And at the end of it, I thought, oh my God, I better be tested. And so he went to his family doctor, and his family doctor was a good one. And he says, well, let's look at your risk, and then figures out that he's moderate to high risk. He says, I'll send you to a cardiologist who can evaluate you further. And the cardiologist then orders the CT angiogram. It's difficult for our system, for the family doctor to order the CT angiogram in the regular healthcare system, but he can order it at the private lab. But you want a cardiologist involved. By the time you're getting a CT angiogram done on you, you want a clinical cardiologist quarterbacking your care. Because the interpretation of those tests we learned from the 16th century, from Reverend Thomas Bayes, that you can't look at a test in isolation of the total human being. And that requires a clinical cardiologist with experience to do that. So you don't want to just rush to Bellingham or Seattle and just get your test done. Well, you could get it done, bring the result, and then have your cardiologist here look at it. That could help. Or you use me, which is the work I do now of cardiac consultation and pro bono medical navigation. And then I assess and talk to you and discuss everything with you, and you transmit your CT angio to me on the phone, on the WhatsApp, and I put it all together and help you with it and help you navigate how to go to the cardiologist or what to say or how to deal with it. So in Canada, it's a difficult problem. It's different in Quebec, it's different in Ontario, it's different in BC. But the key is you. You have to be motivated to get your cardiovascular risk assessment done. Number one, and the most important. And you can be your best advocate. Then you need a doctor who understands that coronary risk assessment is very important, because this is a disease that has already started in you. It is a slowly progressive, insidious disease. And even though you are, quote unquote, relatively healthy, you could have a heart attack tomorrow. So a doctor has to know that. And the only way to truly know the risk level is to have a view of the artery. You can do it by carotid ultrasound, duplex scan, looking at the carotid artery. You can do it as a Doppler scan of the femoral arteries. You can do it as with the coronary CT angio scan of the heart. All of these things give you an indication of what's happening in the wall of the artery and if the lumen is getting impinged. So in Canada, you need yourself first. Motivation, persistence, and being your own advocate. You need a doctor who understands that risk assessment is very important, because the first event could be a heart attack or sudden death. The disease is insidious and progressive. And you need a situation where your risk profile is assessed properly. A lot of it you can do yourself with online calculators, but you need the blood tests, and then you need that to refine it further. So that's the way to get it done. Or you go to the private healthcare centers and have a specialist there order it in a private system and look at it. Sometimes it's worth the money, sometimes it's not the right thing. This is where people like me come along, and somebody calls me from Waterloo, or somebody calls me from Prince George, and he says, this is the situation. You think I should need a CT angiogram? How we should proceed? I go and help him with the risk assessment, and then navigate the situation with his doctor, and then with his cardiologist, if he's got one, or someone that I know in Prince George, and arrange his coronary CT angio. So that's the work I do now through my medical consultation and medical navigation. But the key is yourself first. You have to be jolted into action. You have to be persistent, and you have to get the doctor to understand that just the blood test or just looking at you on a complete physical may not give you the freedom that you're going to be not having a heart attack next week. So all of that plays a role in this risk assessment and able to get a coronary CT angio. Most of the time, they will order a stress test, which is a good secondary level test after the blood tests. But sometimes they will order a stress test with a nuclear scan, the thallium or the MIBI scan that I told you about, looking at perfusion. That's a tertiary level test. Or they will do a CT angio, which is another tertiary level test. So there is levels of testing, and it can be done progressively, or in a high-risk situation, you can go directly to a CT angio or directly to an invasive coronary angiogram. And that's the job of that clinical cardiologist to do for you.
Well, thank you so much, Alnoor. Shall we, end the session now? And, maybe people can email you to ask more questions. There are some more questions in the chat, but maybe it's gone on for almost 3.5 hours.
Right.
And
So-
maybe people can email you if you're okay with that.
Right.
The questions, or they can even, reach out to you for your medical consultation and navigation resource that you're offering.
That's right.
Which is very, very kind of you.
So whether you're following the 0030 program or my S Secret Successful Survival program, and you have questions or concerns, call me, WhatsApp me. This happens to me every day, 24 hours a day, because people get to me from different time zones. If you have concerns about your testing, your medications or something, call me, ask me, because I can guide you. I will strengthen the relationship between you and your doctor and not worsen it. And I will be able to help you navigate through the process. So that's a very important issue. And or you can email me, and I'll be happy to answer any new questions that you may have.
Well, thank you very much, Alnoor, and thank you all of you for sticking around and joining us in this lovely, very informative session. So thank you, everyone, and thank you, Alnoor, for committing your time and educating us. And it was just an absolutely wonderful talk.
Well, I first of all feel extremely privileged to have gotten this opportunity to transmit this knowledge that I have acquired, and knowledge is for sharing. And secondly, I have a request of all of you. Please spread the word. Start with your children and grandchildren. Protect them. It's your responsibility. And then spread it further to your friends and other groups. Spread the word, spread the knowledge. And that is what ultimately saves more lives and makes less people disabled.
Dali, Dr.